maybe I'll just start with a question for James. As I said, your talk really, I guess, raised some important points. And, one of them, which I kind of am interested in, was your comment about, technology and understanding, where technology is useful and what we should be using, and how we've learned quite a bit about that through COVID. I don't know if you want to kind of unpack that a little bit and give us your kind of summary of where we should be heading in terms of that space, because there's a lot of enthusiasm, but sometimes it's misdirected.
Yeah, it's probably a 20-minute talk in itself, Ben. So look, I think from a baseline of highly effective, highly safe services, I think the first thing to acknowledge is the bar's pretty high. Okay, so you need to be certain why you're putting technology in. Are you putting it in to give you a particular outcome? Are you putting it in because it makes the clinician feel better? The representative of the technology company tells you how great it is. Like, why are you using it? And so I think there's a fairly narrow window where it helps. There's clearly some benefit in long-term health management for patients. So the chronic disease type patient, I think there is pretty good evidence out there that if you can engage them in a program of chronic health management through the use of technology, they get good outcomes. And that's all about their engagement. And if that's the window to engagement, great. But do they need a live monitor that's on them 24/7, or do they need to send you their weight, their blood pressure, their observations once a day, every other day? I think you need to make some practical decisions around some of that. I think what we learned in COVID was, you could put all sorts of monitoring in, but one indicator gave us a really good outcome as to how you're traveling, and it was predominantly around what's your oxygen saturation doing. Okay, so I think in the whole technology space, there's some really slick looking devices out there. The real nuts and bolts of it is, what are they actually adding? And if you're going to generate all this data, what are you going to do with it as well? So if you're going to have live feeds, if you're going to have all this really whiz-bang stuff, what are you doing at 2 a.m. when the number drops off? Which is probably because the patient's rolled over in bed and the monitor's fallen off them. I mean, anyone who's worked in things like intensive care and on cardiac wards and things overnight knows that it's the background noise. So you know that you get all these alarms in the middle of the night, but usually it's because the patient's rolled over and one of the leads has fallen off. So what are you going to do with that with them at home? And are they the patients you really want at home anyway?
Excellent, thank you. I think that's a really, really good summary of things, and very helpful. Now, there's a few questions that are popping up on the chat. The first question, maybe I'll direct to everyone, which is really about, and James, you touched on this, and I think, Kate, your work touches on this as well, but Lydia, you have a lot of experience in this, about whether we're using things like, criteria-led discharge in our pathways, whether we're using kind of those, I guess, really specific things to facilitate, managing the length of stay. Don't know if anyone wants to comment on what they're doing and how they're doing it.
And it's Kate. Could I just make one comment related to the last question? And so what we did, when everyone was very keen to use oximetry with COVID, and we just weren't sure. We weren't sure if it was going to give us a headache, if it were actually be useful, as James was talking about. And so we've just had a look at all our data, and we think really with Delta, if you were short of breath, you should have been in hospital well before that point in time. And yet with Omicron, fascinatingly enough, everybody seemed to be short of breath. And when we first were using the oximetry, you could make a clinical decision independent of our oximetry, whether you decided to send them in a hospital or not, because it wasn't validated. And then we started looking at all our data, and we actually found oximetry very useful for keeping people at home who were short of breath. That's where we found its real value.
Yeah, thanks, Kate, for adding that. And I think, I'd reflect that in our program as well. And that's a lot harder to measure, isn't it? Because really what you're doing is you're finding people with normal saturations who feel short of breath and reassuring them that they can stay at home. But, that's fantastic that you've looked at the data in that. I think hopefully there will be some more publications about the use of oximetry in COVID, because, you know, it was very widely used and it's not without complexity and expense. And, you know, there should be something to help us focus on exactly, you know, what it's doing and who it's doing it for. So looping back to the question about criteria-led discharge, I don't know if anyone wants to comment. James, do you use any criteria-led discharge in your program?
In my current program here at Cabrini, it's probably not a clear criteria-led discharge, i.e. they must have X, Y, and Z in order to be discharged, but it's really that they're following their care pathway adequately. And you can usually pick, as you're heading towards whatever your length of stay is it 3, 5, 7 days for uncomplicated infections? Is it 42 days for complex endocarditis? You're following the journey of the patient. And I guess a bit like, what are you doing with the oxygen number? There's some clinician intuition in some of that, but there's clearly, it's almost like there's checkpoints that need to be met. You know, bloods are stable, patient's doing well, X, Y, and Z is resolved. So you can clearly plan their discharge and you can plan it some way out, but we're not using a true criteria-led discharge as they would post a surgical procedure. You know, bowels are open, drips out, patient's ambulating. It's a little bit grayer than that, I think, in my context anyway.
Yeah. Lydia, I don't know if you want to comment on that at all, you know, with your AMS hat on.
I think I probably agree with James. I mean, for HITH patients going on for IV antibiotics, you know, we have criteria-led discharge commonly so that patients can leave that morning, you know, if they meet this and this and this criteria. But I guess maybe we can think about, you know, for HITH patients, you know, I often talk about, you know, has the PIC line gone in? Are their numbers going down, not up? Tick. The home team are happy that the allied health assessments have been done. Tick. As our HITH nurses seen them and are happy about their home situation, and tick. Has the pharmacy got the bottle ready? Tick. Then they can go. And I say explain that all to the nurse. So perhaps we can, you know, you can think about it like that. Perhaps we should be better at documenting those kind of criteria so that everyone is aware on what has to be done, because often there's that not awareness of that on the wards, and the teams will think that they can go home on HITH and they see actually they've got these 5 things have to happen before we can do it. And then that means that those things, once they get used to that can probably happen more efficiently.
I think you've actually picked up a second point there, which is really good. You know, there's 2 points of discharge here, aren't there? You know, there's getting the patients from the hospital to the HITH program, and certainly in our service, we've done a lot of work to decrease the friction at that point. You know, we were a number of years ago finding a lot of delays in getting patients out of the ward onto our program. And then there's that separating the patient from the HITH program when they're well enough to go. And, you know, they're kind of different challenges, but, you know, really kind of the same in some ways.
HITH to home is a challenge too, and that involves kind of careful, sometimes separation of HITH from the patient who really likes it. So yes, it requires kind of talking them through that, so that, because patients love HITH, we love HITH, you have to often kind of anticipate that they might want to stay on, which they often do. Yeah,
no, look, I think James touched on that very well with his comments about the length of stay. Maybe we'll just move on. There are a couple of questions here about oral agents, Kate, given your very, very interesting talk, and I have some questions as well, actually. But I guess Jason's put up a question, being the pharmacist and pharmacologist, about how you choose, you know, which oral agent you choose and how you select an oral agent from those available for a particular indication.
Well, therein lies the art and perhaps not science. So I guess, you know, every medical decision we make is within clinical context. So, you know, there are certain reasons we'll use medications, you know, side effects, allergies, drug interactions, etc., and the condition we're treating, and whether the drug will penetrate where we want to go and in acceptable doses. But, you know, what is the difference between clindamycin and Bactrim? I think it's physician preference. And certainly after we started seeing a lot of hyperkalemia, there seemed to be a lot more clindamycin being used. I saw a question there around the actual dosing. And again, that's often taken from somewhere like the Aviva trial. But if you're lucky enough to be in a centre where you can do TDM for certain agents, sometimes that can be quite interesting just to see what sort of levels you are actually achieving with the caveat, how do you use that and what does that mean? There's a comment there around AMS, and again, I don't view these agents as being separate to AMS for any other, whether it's on HITH or whether it's in the community by GPs or whether it's in the hospital. There needs to be good governance of all antibiotics, and our HITH program goes on the HITH NAPS program to make sure that we have some sort of overview of what we use. Our HITH models in Queensland tend to be more nursing run than medically run. And when we discharge from the Royal, we often, patients often come to the Royal for, the quaternary services that it might offer. So there might be a burns patient, for example, and then they're discharged to somewhere in Western Queensland. And so we discharge to many different HITH services with many different capabilities. And we actually use our HITH team. One of their main roles is to make sure that we have safe discharges across the state. So although we have a local Metro North HITH service where there is governance, we became very involved in the safety of patients being discharged to other services, for reasons of safety. I hope that's answered your question.
Yeah, thank you. That's really good. I was going to ask you actually another question about therapy from the comment you made, and it's one of my concerns with the oral therapy is that we really are substituting, often more, more complicated, more side effect, more toxic agents, for therapy for what we traditionally have used, pretty straightforward beta-lactams. And you mentioned that comment about, whether if we're using something like clindamycin or fluoroquinolone, whether we really need to use it for the whole course of therapy, or whether we can, kind of do a staged approach. And you also mentioned that there's no data, but I was just wondering what your practice is in that and how you've addressed it and whether you do that.
It's interesting, isn't it? So I'm probably quite conservative in the sense that if I have say we have a Staph aureus bone and joint infection, and if someone has a bacteremia, certainly for those initial 2 weeks, I still stay on an IV agent. I don't, with Staph, feel there's the evidence yet to swap to a highly bioavailable agent, although there are published prospective cohorts. I guess then the question is, if we talk about before these agents, often we'd give, for example, say we're giving a 3-month treatment for a prosthetic joint infection. At 6 weeks, you might swap from the IV to a more lowly bioavailable agent like dicloxacillin, for example, and patients did very well. So in my mind, the question is what you do with that 4 weeks in between. And so, the options are, IV, highly bioavailable, or a lowly bioavailable agent, so to speak. And I often use highly bioavailable agents in that 4 weeks. But if someone's uncomplicated, I get patients out quite early on a highly bioavailable agent. And I'd have to say, if I look at the practice of my colleagues, that's very common. We've had our HITH service in terms of antibiotics. Really, HITH for us is not really antibiotics to a large extent anymore, to be honest.
Mm. And James, how do you approach it?
Yeah, I think we're probably still fairly conservative in terms of our oral switch. And again, my context is a large private hospital, so there's a huge number of VMOs all acting effectively as solo practitioners. So whilst there's fairly broad agreement within the practicing ID physicians around, early oral switch when it's appropriate in all the indications and reasons Kate's illustrated, I think there's still a fair degree of conservatism around some of the long treatment courses and sticking with, if you've already been in hospital for a period of time, you're on a narrow spectrum agent that's IV, why change to a broad spectrum agent because it's oral when you have the availability of the HITH service? Again, it's a thin end of the wedge, isn't it, on using it because it's there as opposed to, picking an alternative course. And some of it's shared decision making with the patient, putting to them the pros and cons of their treatment options. They're options. They're not you must have one or you must have the other. It's options.
Yeah, thanks. I think that's a really important point, isn't it? That the patient needs to be at the centre of these decisions about what therapy we choose and why we choose it.
Yeah, and I think that's really critical, and in any context, that's really important.
Yeah. The other comment would be that not everybody tolerates these agents as well. So it's not like everybody can be moved onto them. The nausea and vomiting from Clinda can certainly be quite bad for some people, for example.
Yeah, yeah. Now, I can just see one question that maybe Lydia would be well placed to answer, and then we're going to ask Lydia you some questions about the COVID program. But this is really just about TDM and, you know, using more complicated and toxic therapies on the general HIT program like vancomycin and gentamicin, and really about how we kind of manage them in terms of monitoring, and especially in patients who are on dialysis, you know, what we do to kind of facilitate them.
TDM.
I guess the reason I ask is because you've done a lot of work on our vancomycin procedures for our program.
Vancomycin procedure.
Yeah.
So, look, the key really just is to have the pharmacists on board and to be able to educate the nurses about when to take it. We've just got a new program, Dose Me, in which has really been changing everything now. It's not validated for infusions, but I think will be soon. And look, we work closely with we try and set up dialysis-friendly protocols and visit our patients in dialysis so they don't have to come in. In terms of monitoring vanc, look, our nurses are really good at it. We have good communication about when to take the levels. If we get spurious results, we just always recheck them. You know, we have a good team. We have regular communication. We have a protocol.
Yeah.
So what more can I say? I'm sure it's a familiar topic for all of us. Yeah.
Yeah. I think, you know, you just make a couple of really good points there. One of which is that the levels just have to be kind of baked into the therapy.
Yeah, we have we have different, we take the level and then we have 20 plus or minus 3 for our baseline level that we're aiming for. All the pharmacists and the nurses know that, and then we adjust it to a higher level for infective endocarditis or, you know, high concerning infections with a large volume of that we really want a slightly higher level. So I think having the HIT MDT each week where we look at all their levels, we make sure that they're, you know, that they're on the right track is really useful. Yeah. So communication and regular feedback is really important so nothing gets missed.
Yeah. Probably one of the challenges that we don't have that others do, and, you know, Kate, you might have this with some of your patients, is a very long turnaround to get the levels back, you know, and dealing with those patients that are kind of at more of a distance. And
I guess we factor that into the discharge. So if someone was going to, well, it's interesting, isn't it? Because if someone goes to Longreach, they've got quite a close remote hospital. So actually, you know, the nurse, say if I wanted to do a level of cefazolin, for example, the nurse would take it straight to the hospital, which is not very far away, to be frozen and sent to Brisbane. So it's actually relatively easy than, say, someone who's a bit further away in Brisbane, ironically enough. But I guess we use, as you know, more broader TDM, sometimes related to making sure that we have antibiotic isn't being broken down in the heat. So we use it for things like meropenem and so forth to make sure that the patient is getting an adequate drug, particularly in summer months. Otherwise, we bring them back into hospital if we don't find that's the case.
Okay, thank you. Now, Lydia, I think we hear a bit more about the COVID program, because, you know, that has been, you know, a real huge piece of work, and I think there's a lot of learnings to take out of it. Jason's asked a really interesting question actually on the chat, which is really to say that, you know, the program had an incredible amount of flexibility and adaptability to it, you know, which is not a trait that large health services and systems are known for. You know, what kind of, obviously the next pandemic or the next health event's not going to look exactly the same as this one, but, you know, what kind of learnings can we take?
Oh, there were so many things that we learned from doing it. One was to just be really flexible with what we had to do, to try new things, say, well, this is the problem, we'll try this, and then we'll try it for a week, and then everyone can say what they think at the end of the week, and we can cancel it if it didn't work. And so we would just have regular meetings with the nurses and pharmacists and everyone involved, and it was a very democratic process where anyone could put up their hand and say what they thought. And we just had to be flexible because the criteria kept changing, the drugs kept changing. We had surges that went on. So we just got swamped all of a sudden in January, where we had 50 referrals landing our email inbox, and we didn't even have time to look at them. And then physicians would ring up and say, my patient hasn't even been called, and it's because we only had one person on the phone. So we just had to find people. And, you know, lots of our services got shut down, like PAC got shut down. So we just used all of their nurses who were really good on the phone to use for our service. So it was a lot of adaptability. Everything got cancelled during COVID. Clinics got cancelled, and we just pulled people from wherever we could. And so it was a whole hospital effort. It wasn't just us. You know, we had ophthalmologists on the phone. They were extremely helpful. They couldn't do eyes, so we used them. And then we just looked for solutions all the time. And so, yeah, I don't know, Ben, there was lots of things to learn. One is just to keep trying different things all the time and see if it works.
Yeah, I think that's not being afraid to fail, really. You know,
no,
just having to try
failed all the time, and we had bad things happened all the time. But then we really churned through a lot of patients, and that was the key, because the key with these things is the number needed to treat. So if you have to treat a lot of patients in order to get the benefit, they were fairly safe drugs. It's just that we had to treat a lot of people. And so it was, and the difficulty that we always found, and what I never really solved well, was the non-English speaking and low, so, you know, our lots of the people that were coming to hospital were our elderly, non-English speaking, socially isolated, vulnerable people, and they weren't the people that were self-referring in. They weren't seeing their GP, and we missed them. And we never found a solution. We tried when our numbers were low with getting interpreters on the phone and trying to find them through COVID Monitor, but it was just so hard to try and sort that out, and we never solved it. So I think in the next pandemic, that will be a key area where we have to concentrate on. And I think, you know, well-resourced, you know, literate, interested in their own health, high socioeconomic people flooded our clinic saying they needed these therapies, which they did. They met the criteria, but we never really found out a good way to get to those people. So that's an area where I think we can bear that in mind for the next surges and the next virus that comes along.
Yeah, that was actually my next question, was about that. You know, our health service is a very culturally and linguistically diverse service, and, you know, I think you've addressed our kind of, you know, challenges in really engaging that group. I don't know if James, you know, or Kate, you want to comment on that particular kind of issue with COVID in your part of the world?
James, do you want to go first?
You go, Kate.
We did with COVID. We when we had a Delta outbreak involving the north side of Brisbane, it involved a lot of medical people that worked at the Royal Brisbane, and so there was real concern around you know, staffing at that time, but it actually drove a lot of interest by executive. And I remember sitting there, and we had 200 people on our so-called virtual ward, which just consisted of people in a room ringing people with no protocols, no nothing. It was all, you know, very new at that stage, and I've just realised we'd reached our capacity. Like that was it. And so we then had a lot of executive support and direct IT support, which I've never experienced with Queensland Health before, and we developed a very targeted, protocol-driven virtual ward in which we texted people patient-facing surveys that allowed us to stratify them according to an Atlas tool in terms of risk and therapeutics, and then allowed us to do daily surveys that stratified them according to their symptoms and flags, and that generated work processes. So that obviously didn't happen in a day, and it's taken a long time to develop. But, you know, in the last sort of, you know, 6 months, we've probably had about 20,000 people through the ward, and we've delivered drugs to them. We've talked to them virtually with nursing support and concierges, and we've had really good feedback. And so for me, that's been a real change in how we've delivered healthcare. And moving forward, we're now looking at, you know, a virtual hospital and what that will mean for bed stock and what we can do with it. So how that virtual model, I think the problem is that it brings out all the inequities in the community, doesn't it? So it's great if you're IT literate, and it's great if you speak English, but there are other barriers. But we've happened to have very good phone interpreter service, which we seem to have changed contractors, and they've just been exceptional. So that in some extent has prevented many barriers that would otherwise be there. But I agree with you. I think there were many people that didn't get therapeutics that should have. And we went from different models. So we had an opt-in model at one stage where we got a list of every single patient that had a positive COVID test. And that was really soul-destroying in terms of trying to get through the work. But as soon as we lost that, I think we lost the opportunity to give people therapeutics that needed them. And I'm not certain how we get around that, to be honest. But we'll have to require a lot of thought.
I think, I mean, that to me, that probably dovetails back to the very first question in the Q&A, which is use the technology to help you. And those send out surveys, yeah, there's limitations in who they reach, but it was a way of coping with the volume of problems. And certainly that sort of process was used in multiple settings throughout Victoria to try and stratify who needed urgent intervention and who didn't, or who needed, and you could repeatedly survey people and follow the trend, and the computer could actually tell you and then flag to you. And so, you know, it's not NASA in the home, it's a text message, it's an online survey. It works really well. I think probably the only other, and again, reflecting the journey everyone's been on, you know, organisations just got to a, what do you need? Okay, do it solution. There was none of this, oh, our department hasn't got capacity to do this, or we can't do that. It was, okay, here's a resource you can have and do it. It very much moved to a yes answer rather than a, well, we'll think about it, or we might, you know, all the challenges of moving things through large organisations, I suppose. And I guess probably, you know, illustrating the challenges around access in different groups, you know, certainly one of the challenges early with lots of the therapies were people demanding certain treatments who didn't necessarily fit criteria for them either, and managing their expectations and the time investment, and explain to someone who didn't need treatment why they didn't need treatment and why you weren't prescribing them something was very labour intensive as well. But it was obviously really important in terms of their own healthcare, their own fears and anxiety around the diagnosis they've been given of COVID.
Yeah, thanks. I think they're all really good points. And, you know, I think, you know, now that the dust has settled, it's really our obligation, isn't it, to really look back and think about how we pick up those groups that we've been missing and how we make sure that we don't miss them the next time something like this happens, which hopefully won't be too soon. Now, I think we're just heading for time there. Jason, are you about, or?
Yes, really enjoyed the discussion from all the speakers and yourself, Ben. That was a fantastic discussion about all the various, I was trying to avoid the use of the word learnings, but it's unavoidable once it's in the vocabulary, isn't it? But I thought it was really interesting exchange from everyone. So I'm really grateful for that. Assuming that there's no more questions, I might close if you're happy, Ben.
Yeah, absolutely. Absolutely.
So thanks very much for your moderation. Someone like yourself always makes the interaction as wholesome as it can be and ensures that everyone's able to learn as much as they possibly can from the three experts that we were fortunate enough to have present tonight. So thanks very much to James, Lydia and Kate for your fantastic presentations, and of course that nice interaction towards the end.
Thanks, everyone.
So whilst people are still online, I might ask you, if possible, if you could complete this survey. We'll email it out to you anyway, those that were attendees, just to get feedback on the topics that were presented and ideas that you have for questions which you think that you would really like for us to try and address in future seminars. I think it's really important that the collective community helps define what these education programs deliver. And so I'd be really grateful for any feedback that you may have on the webinar tonight, but also for future ideas for upcoming webinars. And speaking of upcoming webinars, I wanted to mention that the final two educational webinars that the CRE Respond is hosting for the remainder of 2022. The first is respiratory viral infections, looking at current and future therapeutics This is a session which has been designed by Dr. Andrew Burke from the Prince Charles Hospital and the University of Queensland, and has some wonderful speakers. You will all receive communication about this, asking you to register. And if you're in and around the Brisbane area, I really encourage you to come to the RBWH Education Centre for a light dinner, but also to be part of the discussion that will occur here. And then finally, a webinar which is focusing on dosing of antimicrobials during renal replacement therapy, as well as extracorporeal membrane oxygenation. And this will have topics related to both adults and paediatrics. This one will be held on the 22nd of November. So please keep your eyes out for more information for both of those educational opportunities, and we hope to see many of you present at that. But otherwise, I'd like to draw this webinar to a close. Once again, thank our fantastic moderator and speakers, and of course the audience for your attendance and the sponsors for making this possible. So thanks everyone, have a wonderful evening.